Okay, I just realized we just had a few PowerPoints left on the hypertensive, so I'm going to go ahead and add in the rest of the information that's antepartum hemorrhage chapter that follows this. I've upgraded your objectives to make sure y'all get a new copy of the objectives since it's due tomorrow. So we had a couple of chapters in there that got omitted somehow, and I'm not for sure how that happened, but I'm going to be sure and put it up with a PDF to make sure that doesn't happen again. I don't know if somebody accidentally may have, because it can very easily be manipulated. Um, just if you just ran your arrow across it and your pointer across it, it could actually delete some of those. So I'm going to go ahead and put it back in PDF form when I get through doing this recording. So we are going to go finish the hypertension and start with the other one. Okay, so your ectopic pregnancy is going to be found in chapter 28, which is your antepartum bleeding disorders. And we need to know about these antepartum hemorrhagic disorders because we do see this a lot in high-risk pregnancies, and that's one of the high-risk pregnancies is bleeding in the early pregnancy. So usually early pregnancy bleeding means that you're going to have usually are in the process of having a miscarriage. We've already talked about the incompetent cervix that's in here, and I want to go ahead and talk about ectopic pregnancy because it is a high emergency situation as well. Any any female patient that comes in that is of childbearing age complaining of abdominal pain, usually on the right or left side, and it is a severe pain, and they're pale and they're diaphoretic, always expect a ruptured ectopic pregnancy. This is an medical emergency, and they will bleed to death if you don't get in there and get it done. And it doesn't take a very big fetus to rupture a fallopian tube. If you have seen a fallopian tube, you know that it's very, very small, and so a fetus can be 8 weeks old and be big enough to rupture the fallopian tube. They have not gotten a science to where they can actually remove the fetus and implant it in the uterus, although I think that would be fascinating to do. Um, because if they have to remove a segment of the fallopian tube, then the chances of getting pregnant are very, going down to 50% because you only have one fallopian tube working. 95% of those ectopic pregnancies occur in the fallopian tube. However, it can occur anywhere outside in the uterus. It can be in the abdomen. It can be on the ovary. There have been a couple of incidences where it implanted in the abdomen and a patient actually did deliver the baby via C-section. So always be suspicious of ectopic pregnancy. They're likely to, what would you think that you think her pain would be more important than her hypovolemic state? Well, I mean, she's in pain, but the only way we're going to get rid of her pain is get rid of her problem, and her problem is that she's having a lot of hemorrhage inside her abdomen, and we need to get rid of, or inside the pelvic that's moving up into the abdomen, causing a lot of pain. So be sure you're monitoring those vital signs and for signs and symptoms of hypovolemia, which you should all know by now. Hydatiform mole is molar pregnancy. Comes in a kind of gray black cluster on the ultrasound. So basically, the hydatiform mole has now they've changed the name to gestational trophoblastic disease. So those words are used interchangeably. You have a complete mole and you have a partial mole. The complete mole doesn't contain any fetal parts because you've had an egg that became fertilized that didn't have a nucleus. So there was only one one set of chromosomes in there, so there could not develop fetal parts. The partial mole contains embryonic fetal parts. An amniotic sac is present. Usually this is when two sperm actually fertilize one egg and causes the grape-like clusters to develop in the uterus. We have to monitor the HCG level. It can also lead to choriocarcinoma, and this is what is so dangerous about a hydatiform mole instead of a pregnancy, because if you go in because you've missed your period or your belly's getting a little big and you have an HCG level done, you think you're pregnant, and then when you actually levels get way higher than they should be at this gestational age the fetus should be, then we start thinking about hydatiform mole. And then you have to inform the mother that she's not a mother, that she has a hydatiform mole. What do you think this woman feels right now? She feels a loss, and it's kind of a special loss because she wasn't really pregnant, but implantation occurred for her to actually develop the hydatiform mole. So it's really difficult to take care of these patients. This is how it manifests, how you know that your patient has a hydatiform mole. There's vaginal bleeding. That may be when she comes in saying, I'm having vaginal bleeding and I know I'm pregnant. Vaginal discharge is kind of a dark brown, prunish looking color. The uterus is going to be a lot larger than what she's supposed to be at her gestational age. She's going to develop anemia because there is no placenta to receive any of the nourishment that's going there. Excessive vomiting, nausea, usually is from those high HCG levels. Abdominal cramping occurs, and hypertension usually develops before 24 weeks. And those HCG levels have to be monitored carefully because they're usually higher than they should be. Well, usually during your pregnancy, your HCG levels increase quite a bit, and then after a certain gestational age, they start going down. With a hydatiform mole, they do not. So this is how we're going to have to manage our trophoblastic disease, gestational trophoblastic disease. Sometimes you will find that the little grapes will pass spontaneously, but most of the time you're going to see you have to do a suction and curettage to get all the little grapes out. If mom happens to be Rh negative, we still have to give her RhoGAM as if she was pregnant because the body has responded as if though she is. We have to do serial measures of HCG over the course of a year. You check it for so many times during the first few months, and then you go to checking it even after that. So be sure that you know what they are. Usually we do the HCGs weekly until the level turns to normal, and it stays normal for 3 weeks. And then we do monthly measures for 6 months, and then for a year. So it's not like you're only going to get HCG tested once a year. You're tested all throughout the year and then yearly. Why do they have to take oral contraceptives? Because HCG is our level for testing to see if the hydatiform has come back or has not been cured. And we got to prevent that pregnancy so we can have an accurate measurement of the HCG. This will help prevent her from developing on into choriocarcinoma. So that's very important when we're taking care of hydatiform mole. And that basically takes care of chapter 28. That's all I want you to know out of chapter 28. It's not a lot, but it's important. I'm going to go ahead and start with your endocrine on chapter 29. So let's get that one up here. I don't think it's very long. Okay, this is chapter 29. Okay, diabetes is going to be our most common endocrine disorder associated with pregnancy. You have to know the difference between pre-gestational diabetes and gestational diabetes. I know Miss Candler is going to do a knockdown, drag out job of diabetes when she teaches it next week, and it's going to be a lot of fun for you guys. The main thing with someone who is pre-gestational, who has pre-gestational diabetes versus gestational diabetes, is that if you have diabetes before you become pregnant, it's very important that you have a good control over your glucose. You want to make sure that you have had it in good strict control for at least 3 months before you become pregnant. If it's not in control, a lot of congenital anomalies occur in babies that are born to pre-gestational diabetic moms, and the babies will die. Sometimes, a lot of times, they will die in utero because mothers go through diabetic ketoacidosis, in and out, metabolic syndrome. They do that quite often, and it's detrimental to the fetal growth, and so you see a lot of fetal losses with those that are pre-gestational diabetics. The gestational diabetics, on the other hand, they're not affected until after about 24 weeks. So their developmental stage of the fetus has been normal. They don't have a problem. So you don't see the congenital defects that you would see in the pre-gestational diabetics. You'll see the heart defects and all different types of congenital defects that you may see. And some of it's incompatible with life. But with the gestational, what you worry about is the baby becoming too large. So because as mom needs more and more control over her sugars, the baby's getting more and more sugars, and it's just growing and getting used to all those sugars. And so it's going to be large for gestational age. When it's born, it's going to be cut off from its glucose supply and become hypoglycemic. So these are things we need to watch for in the difference between the two. Once a patient becomes pregnant, especially the pre-gestational diabetes is the one we're talking about, that's going to be affected in these first 3 months, because the gestational isn't affected until 24 weeks when they develop gestational diabetes. So the pre-gestational diabetic will become hypoglycemic for the first 3 months. Why do you think that is? Because she's developing the baby, and the baby's getting a lot of the sugar, so she can become hypoglycemic. So her insulin needs are going to decrease. During that second and third trimester, when your placenta starts producing insulinase, you're going to see an increased need in insulin. The placenta produces the hormone to try to block the mother's insulin so the baby gets more of the sugar. So her insulin needs are going to increase because her glucose is increasing. Once the placenta is delivered and you get rid of the insulinase, insulin needs usually start to return to normal. But during that first 24 hours after delivery, you're going to see a drop in the need for insulin right away, because now you no longer have all that insulin that you're taking. You've got all this insulin, you don't have any sugar in there. So once it comes out, there's nothing to block it, and therefore you're going to have too much insulin, so you will need to decrease the insulin after delivery. So you decrease the insulin needs at the first of your pregnancy, it increases in the second and third trimester, and then it decreases immediately postpartum, and then will eventually return back to the pre-pregnancy state once they have stabilized after pregnancy. If they are breastfeeding, they may not be have to use as much insulin. They may be able to keep it lower for up to 6 to 9 months. And again, the uncontrolled diabetes is going to lead to macrosomia and congenital anomalies. Now, our gestational diabetics versus the pre-gestational diabetics, they're tested at 24 to 26 weeks. The fetus doesn't have any problems as the glucose is not an issue until that second trimester. Usually gestational diabetes can be controlled by diet and exercise, but if they can't control it, then you'll see insulin or metformin being used if they can't control it with diet and exercise. The same interpartum care is with insulin-dependent diabetes, and once the expulsion of the placenta happens, then it resolves the gestational diabetes. And usually if you do a glucose, but you can't see the, I can't move it. So anyway, usually you will see the, you should do a fasting glucose the next morning after delivery to check to make sure that she doesn't need any further interventions through her stay. We do need to teach her that she will probably develop diabetes later on in life. Type 2 usually. They will develop it later on. So, our next thing we want to talk about is hyperemesis gravidarum. And this is a patient who, early in their pregnancy usually, but sometimes during the entire pregnancy, is vomiting uncontrollably and losing weight. They have to lose at least 10% of their weight to be considered hyperemesis gravidarum. They think it's related to those high levels of HCG that causes a lot of nausea and vomiting in that high datiform mole. Their blood pressure, of course, gets low. Their pulse has to increase because their cardiac output is decreased because they are hypovolemic. They are usually exhibits poor skin turgor, and of course their electrolytes are going to be messed up all over the place because they're throwing up constantly and they can't keep enough food down. We should check their urine for ketones to see if they are having ketonuria. And our treatment for these poor little young ladies, according to our UMS hyperemesis protocol, is they need to stay NPO until the dehydration is resolved and at least 48 hours after vomiting has stopped. That doesn't mean that they're not getting some kind of fluids. We're giving them IV fluids, and we're giving them, depending on the doctor, you get different types of fluids. Sometimes the doctor will give a D5LR and then give one with vitamins in it and then give another one with other things in it, and then have these rotate. So you have to be careful with what fluids that you're giving. We use corticosteroids to help in the treatment as well. You need to be sure and do accurate I&O, your daily weight, your cool room. Don't go in there and open up their first meal right into their noses where it makes them feel nauseated and want to vomit again. These patients need to be encouraged to eat small, frequent meals throughout the day instead of eating one large meal, and to not drink fluids when they eat. Hyperthyroidism is, Candler's going to go over it in a normal person that's not pregnant. People who are pregnant and are hyperthyroid, have hyperthyroidism, are at increased risk for preeclampsia. We treat them with PTU. Of course, some of your side effects is a granulocytosis. They usually present with a sore throat and fever, so you want to be sure that if you have a pregnant patient that's hyperthyroidism and they come in saying they got a sore throat and fever, you need to check to see if they're taking PTU. And if they are, call your MD and talk to them. Breastfeeding is not contraindicated in hyperthyroidism, but it requires that the infant has a lot of blood tests drawn to check to see if they're having any problems with their thyroids, as that medication does pass through the breast milk. It's one of the very few that do, so we don't usually encourage breastfeeding, although it can be done. Hypothyroidism and PKU. Usually with hypothyroidism, used to be you never worried about a patient that hypothyroidism being able to get pregnant because it was impossible. But now that we have medication to treat hypothyroidism, we're seeing a lot of pregnancies occur, the women that have hypothyroidism. You'll see weight gain, fatigue, cold intolerance, constipation. These are all signs of hypothyroidism in normal and pregnant women. If it's untreated during pregnancy, of course, preeclampsia, abruption, and stillbirths are some big risks. Levothyroxine is what we usually give for treatment. PKU is phenylketonuria. If mom has phenylketonuria, then the fetus may develop neurological problems from phenylketonuria if mom doesn't comply with her diet. And a lot of times, you're diagnosed with it as a baby, and when you get to be so old, they say your brain has stopped developing and they can start eating all the phenylalanine they want to eat, but that's not how it works. If the mother's planning on becoming pregnant and she's not stayed on her PKU diet, she needs to get back on her PKU diet, because that will cross over into the fetus and the baby will have PKU intolerance possibly from the mom. We definitely discourage them from breastfeeding, because the same thing, they have to be, the breast milk has to be tested, the baby has to be tested to see if they can actually tolerate the level of PKU. And that's the end of that one.